Content presented in Cheshire Corners is for educational and informational purposes only. Please consult a legal professional if you have any questions or concerns about the content of this disclaimer, this series, or the legal implications surrounding psychedelic substances in your jurisdiction.
We are here at this conference. It's called the Collaborence Conference. We are here to focus on collaboration, education, community, innovation, and we're learning more and more that the effects of these medications last longer than the drug lasts in our bodies. A contraindication is where two variables, I'm going to try to use my fingers together. Two variables like drug, or a health condition and drug are usually avoided, generally avoided, because generally speaking, not always, nothing's absolute, generally speaking, the risk is thought to outweigh the benefit.
Welcome to Cheshire Corners. My name is Rita Tsalyuk, and I will be your host as we trip through the looking glass. Dr. Kristin Speer is a residency-trained, board-certified pharmacist whose path towards trauma recovery and safe access to care began as a student at Chatfield High School, sister school to Columbine, where she witnessed the massacre unfold from lockdown. In the months that followed, Chatfield shared her classrooms with displaced and wounded Columbine students, an experience that instilled in her a lifelong commitment to healing, safety, and dignity in healthcare. Over the past 15 years, she has practiced in hospice, palliative care, pain management, psychedelic medicines, and prescription drug benefits, all these with a focus on pharmacologic safety and complex regimens. Kristin co-founded the Psychedelic Pharmacists Association, created the Magic Mushroom Interaction Checker, and co-developed screening criteria for Colorado's Natural Medicine Health Act. Today, her work bridges practice, policy, and harm reduction to ensure psychedelic therapies remain safe and accessible. Today, she will be speaking to us beyond psychotropics from Collaborence Conference 2025 about relevant magic mushroom interactions you don't want to miss.
So I like to know who's in the room. Who in here, show of hands, is a guide or facilitator, licensed or unlicensed? Okay. Who in here is a therapist? Okay, both hands, I love that. Any providers? Awesome, great to see you. And advocates, allies of plant medicine. All right, I think all of our hands can go up for that. Well, I appreciate you all being here in the room with us. And as we were introduced, I'm a pharmacist. I was trained in Western medicine, and as several of us probably all have been trained in Western medicine as well. And rigorous scientific research, evidence-based clinical practice, and guidelines, they all carry a lot of weight, right? I think Western medicine, we can all agree, has its place. We've all benefited from it, myself included, many times. But what I really want to say, the reason I'm bringing this up is because therapists, guides, facilitators, healers, I believe that the care, in some ways, the care that you all are providing, the human care, is more profound and more healing than the health care that Western medicine can deliver. I truly believe that in a lot of ways. And so I do think, and I think all of us here probably believe to a degree, that there is absolutely validity and value to various forms of expertise, wisdom, lived experiences. We are here at this conference. It's called the Collaborence Conference. We are here to focus on collaboration, education, community, innovation. And I think a lot of us are here because we feel a sense of responsibility to do well, to serve others well, to do better. As the panelists just said, to protect access by avoiding unnecessary harms, to continue to learn. And so I appreciate you choosing to be here to listen to this talk today. I think I'm going to bring some different perspectives as a pharmacist. And I also think that we can all agree that there's always room for improvement. What's the biggest room? The room for improvement. So I was at a meeting or a meetup about a year ago here in Colorado, and I was listening to a thought leader therapist. And one of the things I remember her saying is that there aren't very many interactions with psilocybin, maybe a handful of psychotropics, right? And we just listened at the last talk, MAOIs, antidepressants, antipsychotics, lithium, and yes, those are true based on available evidence today. But the reality is, we as pharmacists know that there's actually a lot more to it than that. And to claim something like that pretty early in the game, in our understanding of drug interactions, I think is bold. So it makes sense, right, that we're talking about these, because in clinical training programs, facilitator training programs, this is what is taught in curriculum. It's what is reflected currently in a state program and on screening forms. It also makes sense that we would start with a population, psychiatric population, looking at psychotropic interactions, because that's where the most relevance and the demand lies. But what we need to do is broaden our scope, because as demand expands, as regulated access expands, we're going to be encountering a much broader population with more chronic conditions and a lot more medications. So we need to focus on these types of interactions and be prepared for those and be able to manage them. I'd like to set the stage with a little more some real world evidence, not just clinical trials. So some of the most robust evidence that's come out recently came from the Rocky Mountain Poison and Drug Safety Organization here in Colorado. They just published a report on the National Survey Investigating Hallucinogenic Trends, otherwise known as the NSIHT, not to be confused with anything else. But I think this survey is important for two main reasons, at least, especially as we compare it to global drug surveys. This particular survey is the biggest and most robust survey collected on adults who have reported psychedelic use within the past 12 months. And they gathered responses from a neutral population, not psychedelic enthusiasts or critics. I think that's really important to the study. They also use particular methods to be able to allow us to extrapolate or apply those results to the broader US population. One of the outcomes they reported on was the perceived improvements to mental health after using psilocybin. Of course, they looked at other plant medicine psychedelics as well, but we're here, talking about by a PATA-sponsored conference. So just for fun, does anybody want to guess? Unless you've read the report, you're not going to know, but just to get some engagement, does anybody want to guess what the percentage of participants in this survey reported perceived improvements in their mental health? 70%? 60? 84? 84? I don't have a guess, but I also just want to say I have the full results. Oh! He's sitting back here. Hey! I did let Crystal know we would be reporting some data. So she said, that's great. So it is 46.7%. Now, at first glance, I thought that's actually really good. I don't know what your thoughts are about that, but then on second thought, it also says that about that 53%, over half, the majority of respondents didn't choose agree or strongly agree. They chose something else, like neutral or disagree or strongly disagree. And so the point here is that it paints a picture that there's still room for improvement. I'm a little surprised by these results. Maybe I'm biased. I was expecting them to maybe be flipped, that the majority would say they experienced mental health improvements. And I think there's a lot of variables and explanations that go into these numbers. But my point is, hey, I think there's an opportunity to increase these numbers. The other major survey I wanted to point out, just again, we'll get to drug interactions in just a moment, still setting the stage for our need for improvement, is a comprehensive survey on the extended difficulties that people perceived after they had a challenging trip. And this survey was conducted on over 600 participants who reported persistent problems beyond at least 24 hours after a challenging trip. And 1 in 3 reported difficulties that extended more than a year out. And almost 1 in 5, 17%, reported extended difficulties after a challenging, difficult trip for more than 3 years. So again, I do think there could be a lot of explanatory factors. I think in this particular study, a lot of the participants weren't facilitated. Of course, they don't, many were alone. But from a pharmacist's point of view, I also don't see anybody studying the effects of prescription medications or supplements or OTCs and the impact they may be having on some of these outcomes. And so a quote from yours truly, a question is, what if neutral, negative, and unexpected experiences and outcomes in particular were due to unrecognized drug interactions? We just don't know. So I'm here to tell you, let me back up one. Kind of to this point, 6 in 10 adults reported taking a prescription drug within the past 12 months, based on a Kaiser Family Foundation study. 1/4 of US adults reported taking 4 or more. So medications and substances in general are very much a part of our lives. They're not inconsequential, and we're learning more and more that the effects of these medications last longer than the drug lasts in our bodies. So I'm here to tell you, I'm going to use a very Western word, drugs. If there are drug interactions, if there are drugs, there are drug interactions. Just like if there are people, there are going to be people interactions. We're encountering each other all the time. The good news is interactions are manageable. There's usually something you can do about the risk. I also like to say sometimes ignoring drug interactions is like ignoring traffic rules and infrastructure. Can you imagine putting a blindfold on and walking across Colfax Avenue? For those of you who are local. Eventually something might happen. Maybe most of the time nothing will happen, but if we continue to ignore the possibilities of these various interactions, eventually something serious is going to come along. And I think we all recognize that. More good news is that interaction doesn't equal contraindication. That's a good thing. And just for fun, is there any brave individual who might want to explain in their own words the difference between an interaction and a contraindication, just to kind of get some engagement? I promise I'll be nice. I'll probably say you're right. Okay.
Would contraindication mean equate to some harmful effect as opposed to some effect as an interaction?
Yeah, I think that's just as good as an explanation as any. So a contraindication is where two variables, I'm going to try to use my fingers together, two variables like drug, or a health condition and drug are usually avoided, generally avoided, because generally speaking, not always, nothing's absolute, generally speaking, the risk is thought to outweigh the benefit. The other piece of good news here is that even contraindications can be managed to allow for a safe and supported journey, and I will demonstrate that. Quick story, I had a therapist reach out to me not too long ago, several months ago, and she said, "Hey, Kristin, I have this participant who was going through a trip and she didn't onset for 4 hours. And I had to stay with her until 10 p.m. and we were thinking about wrapping things up and moving on. I'm glad I stayed with her." And I said, "I'm glad too." She said, "Can you take a look at her med list? I suspect there's something on her profile that's causing this." So I took a look, and sure enough, I identified a suspect. I had a psychiatrist reach out to me not too long afterwards, say, "Hey, Kristin, are you seeing this phenomenon where there's this delayed onset with this particular medication?" And I said, "Yes, I'm hearing more and more stories." Anybody have an idea, a guess about what kind of medication we're seeing causing this phenomenon? That's a great guess. Yes. Anti-anxiety, not quite. Yes. Ozempic, our GLP-1s. Our GLP-1s, they're on the news like every day. So as you might suspect, I am going to be talking about GLP-1s along with a handful of other relatively important interactions. I'll admit some of them are more just drug safety than direct drug-drug interactions, but are very relevant to the space. So this case is actually a conglomerate of like 2 or 3 cases I put together for illustrative purposes. This wasn't a single case. We have a 40-year-old female who is overweight, suffers from chronic constipation. She has gastroesophageal reflux disease or acid reflux, back spasms and pain. She also has an autoimmune condition called systemic lupus erythematosus, SLE, that affects multiple organs and systems in your body. And as a complication, as a result, she also suffers from orthostatic hypotension, which is a condition that causes dangerously low blood pressures. People can experience symptoms with that, dizziness, fainting, blacking out, falls. And also a result of her systemic lupus erythematosus, she has moderate kidney impairment as well. Here are her medications. She is a complex patient, although she's on 6 meds. A lot of people are on more frequently. There's our GLP-1, semaglutide. In this case, for weight loss, it's Wegovy. A lot of people talk about Ozempic, which is approved for diabetes, but Wegovy is for weight loss. Once a week. She just recently increased her dose to 1.7 milligrams. She is on Prilosec, OTC, omeprazole once a day for her reflux. By the way, if I mention brand name, it's not because I'm endorsing, it's because they're a lot more familiar with the regular audience, and they're a lot easier to pronounce. Cyclobenzaprine Flexeril 5 milligrams twice a day for back spasm, And then we have 2 immunosuppressants for her autoimmune condition, hydroxychloroquine and belimumab, Benlysta, both given once this one given once weekly, this one's daily. And then we have Midodrine, which is a medication known to increase blood pressure in people who suffer from symptomatic orthostatic hypotension, okay? I'll tell you, all of these medications are compatible with each other. We'll see what happens as we walk through a potential psilocybin journey. Just out of curiosity, would anyone feel 100% confident sitting or facilitating with a patient with this complexity? I don't think there's any right or wrong answer here, but I will say none of these conditions or medications are on a screening form right now. Before we go into those meds, I also want to make point out a key point or concept, and that is that most drug interactions, including those listed in professional commercial drug references, such as Micromedics, such as LexiComp, are based more on established pharmacology principles and case reports post-marketing than they are on strong clinical evidence because they're just not studied. That said, let's jump in. So Semaglutide, okay? There are right ways to pronounce these drugs apparently, and I still don't get it after being a pharmacist for a long time. This one, as we just discussed, is a GLP-1 receptor agonist used commonly for diabetes and weight loss. And the problem is that we're seeing it slow absorption and slow stomach motility to the point that people are onsetting hours later, which can be a contraindication. If you're not expecting it and you're in the car or somewhere else, that can be very dangerous, as we know. So the scope of this issue is also that the FDA has recently, well, I wouldn't say recently, they've slapped a label on these drugs due to aspiration pneumonia related to surgical anesthesia and deep sedation. So what happens is, even though people are following fasting recommendations, when they're in deep sedation or anesthesia, there's still stomach content left over because of these GLP-1s. And then when they're under, they regurgitate a little bit, they aspirate a little bit, and the food particles cause pneumonia. It's not a very common occurrence, but the risk is real enough to slap a warning on these medications. And that's just how impactful the gastrointestinal motility and slowed absorption is with these medications. Some people have been tempted to skip a dose. But the problem with that is evidence shows that these medications can take weeks. Sometimes in case reports, it's been up to 6 weeks to 8 weeks for long-acting GLP-1s like this one to be off of it before your full stomach motility returns. But the question is, do we really need full stomach motility to have a good, timely onset of effects from a mushroom? Probably not. The other thing to know about these is that slowed motility is usually more likely if you have recently increased the dose, if you just started the med, or you have gastrointestinal symptoms such as constipation, nausea, vomiting. Our case, she had constipation, and later I found out some occasional nausea. So she just increased her dose. So she's got some of those risk factors for having very slow GI motility and maybe not onsetting for a while. So our strategy for her, I know I'm talking through these because I don't want you to be reading while I'm trying to talk through it and get distracted. Our strategy for her in this case was to skip 2 weeks and to thoroughly grind the mushroom, put it into some tea, and then eat lightly the day before and the morning of so that you're not competing. You don't have a lot of food competing with the mushroom. So in this case, this is very specific to her case. I wouldn't be doing this with somebody who has diabetes or is taking the medication for diabetes. That would be a different plan. Let's move on to Prilosec. Now, I'm going to admit Prilosec doesn't really seem to have direct interactions with psilocybin. But I bring this up because a lot of folks, there's talk within the field of using Lemon-Tek for somebody on an acid suppressant because they're not producing the acid as much. The thought is that you introduce some of that, replace it, because you need acid for digestion. The problem is that when you give a friend Lemon-Tek who has an acid-sensitive condition, like reflux, perhaps they have acid erosion in their esophagus, perhaps they have a duodenal ulcer, a gastric ulcer, they're taking these kinds of medications. If you give Lemon-Tek, that can be really painful. Really painful. So, and if you do it enough or frequently enough, you could be worsening the condition. So in this case, we decided, actually, let me back up. One more point. A lot of people think that Lemon-Tek is required to convert psilocybin to psilocin. When you look at the evidence, and I don't know, are there any chemists in the room? Okay, phew, I'm safe. So, but I do have a degree in biochemistry undergrad, and I looked at this stuff pretty heavily just because, I want to make sure my T's are crossed and my I's are dotted. But the phosphate ester bond that is broken off of psilocybin to convert it to psilocin is usually pretty durable in acid conditions. So the bottom line here is you really don't need Lemon-Tek. It can help maybe a little bit, but the main mechanism of breaking down that cell wall of the mushroom and releasing the contents and making psilocybin available for absorption and conversion to psilocin is pure chewing it down, mechanical breakdown, grinding if you need it. And then the rest of the stuff, it happens, through mechanical processes in your stomach, maybe a little bit of acid, but it's not absolutely necessary. So the strategy for this case in particular was, again, just making sure the mushroom was well ground, give it with tea. We're gonna avoid Lemon-Tek in her case. Cyclobenzaprine is interesting. I know we said we weren't gonna talk about psychotropics, but cyclobenzaprine is a lot like a tricyclic antidepressant. If you have any young kids at home, nieces, nephews, grandchildren, have you ever had that activity, find the difference? I know that's very faint and there's a lot of light in this room, so it's hard to see, but there it is, there's a double bond. That's about the only difference between these two chemicals. So cyclobenzaprine, the medication, is very similar in structure to a tricyclic, and it's very similar in its mechanism as well. Turns out cyclobenzaprine as a muscle relaxant also increases serotonin in your system. It is an inhibitor of serotonin reuptake. It can also increase dopamine, increase norepinephrine similarly. So very similar mechanisms. And the question becomes, are we going to put this person at risk of serotonin syndrome, serotonin toxicity? She's not on any other serotonin increasing medication, so I wouldn't anticipate it. But she is, this is a concern for others who might be on this one. The other thing to consider anecdotally is that tricyclic antidepressants have been reported to cause challenging, difficult trips, particularly with LSD. We know LSD is a classical psychedelic, similar to psilocybin, and with cyclobenzaprine being similar to this agent, and psilocybin being somewhat similar to this agent, with a lot of exceptions, the question becomes, could there be more risk of a challenging trip with cyclobenzaprine and psilocybin? We don't really know. The other issue is that it blocks serotonin 2A, the primary receptor that psilocin acts on. So would we maybe have a blunted effect And that's the complete opposite of what we were just talking about. Are we gonna have a blunted effect or a very difficult trip potentially? And when there's no information beyond this to help make that decision. So our conclusion was it's unpredictable, and most of it doesn't sound very fun. So in this case, with provider partnership and oversight, we did a fast taper. Actually, cyclobenzaprine doesn't typically require a taper. If you look at reports of withdrawal, they're either mild or that there's no withdrawal reaction. But because she had been on cyclobenzaprine for so long, we decided to do a quick taper, and we switched her over to a lidocaine patch. Quick plug, I have a background in pain, palliative, symptom management. Lidocaine is the unsung hero, I think, a very unforgotten or very forgotten, unrecognized agent that can be used for back pain, available over the counter and prescription, and it doesn't interact with psilocybin. So there's your pain plug for today. I think it's underutilized resource. Very mild side effects too when you're using it topically. So there was a little sidebar, but that's what we ended up doing with this participant. And then these two medications are immunosuppressants. So when your body has an autoimmune condition, for those who are not as familiar with autoimmune conditions, your body attacks various organs and systems throughout your body. And those folks will be taking an immunosuppressant drug, sometimes more than one. And while there's really no direct interaction with psilocybin, the risk becomes contaminants. So people who are taking immunosuppressants because you're blocking a lot of what your immune system is designed to do, it's very well known that you're at risk of infection. In this case, she is also a little bit higher risk of infection because she's taking a long-term acid suppressant. When you lower the acid in your stomach, there's a bit more of a risk. It's not very common. I don't want to scare anybody, but it's just an additional risk factor in her case of having a potential infection if we're not getting mushrooms and products from cleaner sources. So the strategy in her case was to make sure we are sourcing from a reliable, well-established source that is testing for microbes and other contaminants, fungus, and so on. That said, there is a non-zero risk. I just learned on a DOR listening session the other day, the guys from Tryptomics, the guys from Friday Ventures were talking about how they're still seeing, a lot of stuff come through. There's a lot of work to do. So even though we might be sourcing from a well-established, high-quality source where they do microbial testing, there's still some room for improvement there. Although it's lower risk than, sourcing a mushroom or a product that hasn't been tested or produced under a sterile technique for those growers out there. So in this case, we used a lab-tested source, made sure she was going with a mushroom product that, I keep saying well-tested, a reliable, trusted source. Finally, last but not least, we have Midodrine. I probably should have started with this one because this probably is the biggest contraindication that pretty much no one is talking about. However, transparently, there aren't hardly any people taking this medication. You might find it rarely, but it's so important, I think, that it's worth putting in this talk. So Midodrine is used to increase your blood pressure when you have an issue that causes dangerously low blood pressures. And there is a black box warning for this medication that causes your blood pressure to increase beyond 200 systolic, particularly when you're lying down, supine hypertension. So if you can imagine, that is certainly a contraindication in a situation where you're going to be in supine position, lying down with psilocybin. And we know psilocybin increases your blood pressure by 15 to 20 points systolic as well. The directions for use of this med even include to avoid it within 4 hours of bedtime, within 4 hours of lying down. So it's certainly something we want to avoid the combination. Thankfully, we can avoid this. And the way that we do that is we don't combine them directly. So this one in particular tends to have a shorter half-life. The last dose in this case was given at least 4 hours prior to bedtime according to her normal schedule. But then we also avoided it the morning of and the day of session. And she at the same time had very close support, careful monitoring, got up slowly, stayed well hydrated to keep her blood pressures up as much as possible, made sure she wasn't falling or dizzy, and she was well guided. And then she was able to take her Midodrine afterwards. So something I would call a contraindication, but something that can be managed too with the right understanding and knowledge of how the medications work. In her case, she also had kidney disease, so we wanted to wait a little bit longer. The active metabolite of this drug is extended in people with kidney impairment. So I'm going to wrap up. That was a lot of information, and I think the point is we were able to produce an outcome that avoided risks, minimized discomfort, and achieved her goals of wellness and mood improvement. And this is just the summary example of the management strategies we put into place. Again, as a reminder, it was a conglomerate of cases representing a couple of cases in this illustrative case. What I want you really to walk away from this with is the idea that just like people who are more layered than they appear, drug interactions are more layered than they appear. And so if there are drugs, and I use a very Western pharmacy term here, there are drug interactions. And well, that was supposed to be for you guys to fill in, not me, darn it. But anyways, we're at the end of the presentation. And I'll give you guys this one. Interaction does not equal contraindication. Thank you. And even contraindications, as we learned today, can be managed to allow for safe and supported journeys. If you guys are interested in resources, stop by our table, the Psychedelic Pharmacist Association. My colleague Erica and I would be happy to chat with you, answer any questions. We have QR cards to the tool here, where you can literally plug in a medication and get an interaction report on up to 10 meds at once. Consultations are also available. And then as a co-founder of the Psychedelic Pharmacist Association, I highly recommend becoming a member. We provide a lot of great education around pharmacology, reducing risks, and expanding access. I think one more final takeaway is I've seen a lot of folks who might avoid somebody with this complexity. And I'm here to tell you that when we partner with people who are experts in their lanes, we can improve access while at the same time reducing unnecessary risks. So I thank you for your attention, and I welcome any questions.
Hi, Martha Montemayor, HCU Mushrooms, Certified Nutritional Consultant. All right, so it's more of I have so many questions, and I've got some observations too. So we are a microdose clinic. We have roughly 300 people in our program right now, and we find that as with cannabis, there are people who simply do not absorb swallowed mushrooms. So we don't use that route of administration. We switch to an oral route of administration. We currently have a dual extract honey where we extract the psilocybin first using sound to break the chitin to release the psilocybin, and then we put it through a traditional rotovap, which brings out the psilocin, and then we suspend it in the honey, and you get buccal membrane absorption, and we are skipping the digestion route of administration completely. with great results with this. Okay, that's number one. Now, number two, let's go into more prescription drug reactions. To my knowledge and in my research, I have found 0 clinical examples of someone actually having serotonin syndrome from combining St. John's wort or other things with psilocybin. But we have had patients who have wound up with, we just call them persistent psychedelic anomalies. These happen with SSRIs, even without the presence of psilocybin. But it's where you have trails that never end, where you have demon face syndrome, where you have visual anomalies that persist even after the trip is ended. And this even happens with microdosing. And we have really good results using diamine oxidase to digest through free-floating histamine and get rid of that reaction. We also recommend to all of our members in our group to use Benadryl as a first-line trip killer if they ever feel too high or uncomfortable on psilocybin. So are you also using DAO, or would you like to learn about it? I've got some in my bag.
I think you need a talk.
I usually teach Introduction to Psychedelic Neuroscience.
That's awesome.
So
I can't possibly repeat all of that. I'm sorry,
I don't
but
think you need
basically,
to,
in a
I'm not.
nutshell, there's a new way to ensure enhanced digestion of mushrooms, which is a common problem.
it's a different route of administration.
Through a different route of administration. And the second point was very complex, but I think related to the fact that sometimes you have some of these persistent phenomenon despite what you're taking, whether it's an SSRI or something else, or not on an SSRI, and a great way to potentially safely abort a trip in most cases if you're using appropriately. This is a pharmacist caveat here, to use Benadryl. And there's also Benadryl as in diphenhydramine. Is that what you said? Yep.
So histamine and intoxication are inexorably linked. And what you do is you use an antihistamine as a first-line trip killer. This works really well with microdoses. If you've eaten like 10 grams of dried shrooms, you're on your own. It's going to do a little, but not that much. So dose does matter for that. But what it is the histamine regulates acetylcholine, which help calm down the serotonin reaction, and it brings you back to yourself typically within an hour. It's very good as a first-line trip killer for low-dose interactions, or if you just need to stop it because you forgot you had traffic court at 3 o'clock or something because you had your parking ticket. Right. But then what diamine oxidase, so histamine, antihistamines stop the formation of new antihistamine temporarily, but they do not get rid of free-floating histamine that's already in the body, and that's where the diamine oxidase comes in. It's also known as histamine digest. It's from pork kidneys, and it digests through the free-floating histamine, so it stops those persistent psychedelic anomalies. Let's talk.
Thanks for watching. If you liked it, please like and subscribe to Cheshire Corners. Tell me what you think in the comments. And as always, don't get psyched out.